I would like to talk today about minimal invasive dentistry. And before we start about how to treat cases like this, I would like to share some emotions with you, because aesthetic dentistry is not only about science, it's also about emotions. And that's the first thing I would like to show to you. Okay, now let's take a look on to minimal invasive dentistry. And the first case I would like to share with you is a case with 8 prep veneers. This case was done in 2003. And as you can see on the next picture, this is the before picture. The lady was missing the laterals, and she was not coming to the clinic because she was unhappy with the aesthetics of the smile. She was suffering from headaches, muscle pain, and so on. As you can see, she has had auto treatment, the retainer is still in place, and we tried to change the canine into a lateral and the first premolar into a canine to create a nice canine guidance. And the next picture shows the preparation I've done in 2003. And to be honest, in 2003, I call this minimal invasive dentistry. From today's perspective, this is a nightmare. This is really an aggressive preparation. I mean, it's 0.8 millimeters. It's not 1.5, but nevertheless, it's far too aggressive. Today, when I do a veneer preparation, I do a lot of no prep cases, but when I do a prep case, I prep a maximum of 0.3 millimeters, with one exception. If it's a case with a discoloration because of an endo treatment, I prep 0.5 of a millimeter. But all other cases, it's just 0.3 of a millimeter. This picture shows how we changed it. We changed the lateral, the canine into a lateral. We changed the first premolar into a canine. We created a nice canine guidance, so we solved the functional problems of the patient. But on the other hand side, we changed also the aesthetics. And what I love in this case is, as you can see in the before picture, the lower third of the face of the patient is very triangled. It's not very harmonic. The face is not ideal. Next picture, it looks totally different. And the only thing we did, 8 veneers. We widened the buccal corridor. We created a very minimal length difference between the central, the lateral, and the canine. And because of this, the face looks more wide. And this is the reason why the face now looks much more balanced. Next case I would like to share with you is a very dramatic case, because this lady was riding a bicycle on Mallorca, small island of Spain, and she has had an accident. And she fractured 5 of their frontal teeth. This picture was taken 2 weeks after the accident. I don't have any idea what the dentist in Spain did to create these horrible results. And I don't know which kind of material this is. But I mean, this is a totally nightmare. This is the lab work, and this is one very important part of the story. Everything what I showed today can only be done with a great lab technician. Me as a dentist, I do the prep, I take the impression, I do the planning, but without a very good lab technician, I can do nothing. And this is the final result. One canine is a veneer, the other canine is a natural tooth, and it's absolutely impossible to judge which one is the prepped one. So this is what I always try to achieve. But now let's talk a little bit more about function. Today we can also solve functional cases extremely minimal invasive. And I will show you later how we do this. This is the patient, and it's a very tall patient. So as you can see on this picture, this is my lab technician, Jan-Holger Bellmann, and he's my size, 195. So normally we don't look up, Jan and me. This guy is 2.10, so it's a really tall person. And we always, in every case, we always use the plane finder system to measure all the inclinations, to measure the ala tragus line and everything. And what you can see here, we have a huge difference between the intercuspidation and the relaxing position. More important, before and after, as you can see, this case was done without any preparation. We didn't touch the tooth structure, with one exception back here because the patient had 2 crowns. We didn't touch any other tooth. Everything is additional. We did the posterior region on the lower jaw and the frontal region from canine to canine on the upper jaw. To me, the most important point of this case is the body posture of the patient. So as you can see, before we started the treatment, the patient was staying like this. After the treatment, the body posture is ideal. So we as a dentist, we can not only change the smile and the face of the patient, we can also change the body posture of the patient. As you see here, the full picture of the patient, it's amazing. It changed totally. He had a lot of problems with neck pain and so on. And after finishing the treatment, absolutely no pain. Even if we have a case with a single crown, we use this kind of approach. So for me, as a dentist, this is a very simple case. I mean, I have to prep it, that's it. For the lab technician, it's a nightmare. Because doing one single crown in the anterior region for the lab technician, it's really difficult. Especially in this case, we have a lot of aesthetic problems. The patient has white spots, a lot of incisal translucency. It's very difficult to create a crown which is really fitting. So again, this is the patient before. Again, we use the plane finder system to measure all the inclinations, the head position, everything. And as you can see, the line from the ala point to the tragus point is totally different, right-hand side, left-hand side. And this is very difficult to see if you use a face bow. So, if we don't have this information, we would think this is the correct alignment of the face. But the truth is, we have to shift it. It's asymmetric, so we have to work on this. If we don't have this kind of information, as you can see, what we normally would do is we would create a crown with this shape. We copy the right central incisor to the left-hand side, and this is the shape. But in this case, if we bring in the lines of the tips of the posterior teeth, we would have a huge mistake within the case. So we have to correct this. And for this, it's ideal to work with the plane finder, because this is the desired shape. If we don't do this and the patient goes into protrusion, he will definitely fracture the incisor ledge. When I saw this picture for the first time, I was totally flashed, totally, because this is art. This is not only lab work, this is really a piece of art. This is the painting of the layering of the ceramic, and it's unbelievable. You see, this is the final result of this case. Left-hand side, natural tooth structure, right-hand side, the crown. This was done with the Ivoclar material, we did this in a live patient course. And as you can see now, when the patient goes into protrusion, it fits 100%. There's absolutely no risk of fracturing. And finally, this was a live patient course, so we have 6 more results. And me and the patient, we were totally unable to decide which is the best crown, which is the best case to cement. So we have 2 restorations, not only with a crown, also with a partial veneer. And at the end, the patient decided to keep the gap because he said, that's me, that's my personality, I don't want to close the gap, but I would love to get the crown which really fits perfect. So, now let's talk about minimal invasive preparation, because this is my favorite thing in dentistry. I always try to preserve the tooth structure of the patient. I always try to be as minimal invasive as possible. That's a key point. And this is a picture, Jan, you know him very well, from Arnold Drachenberg. If this is the situation before we start the preparation, and then this is the prepped case, and if we go and judge this in the mouth of the patient, it looks perfect. There's enough space. This is what we normally think before we take the impression. Everything is fine, the occlusal reduction is totally okay, but it isn't. Because, as you can see here, the tip from the upper first molar goes directly into this area, and there's not enough space. When the patient is starting to move to the left-hand side and to the right-hand side, there's not enough space. So, if this is the coping, there's just the place for the coping, but we don't have any place for the ceramic, for the layering. So we have to do definitely more reduction. But how to know how much reduction we do have to do? This is the final, this is the coping. And this is the bite registration with the coping. So you see it's already, there's absolutely no space. It's already in contact. And this means we have to make sure to create more space for the lab technician. Always keep in mind the recommendation of the manufacturers of the material. How many space do you have to create to get a long-lasting result? Because otherwise you will see a fracture problems over the period of time. For Emacs, we have a minimum thickness on a molar of 1.5 millimeter. And if you don't follow these rules, you will directly run into problems. So, what do I personally use to get rid of these problems? And what I really love are these brand new prep markers. They come in 0.5, 1.0, 1.5, and 2 millimeters lengths, so we can 100% precise create enough space for the lab technician. When I used these for the first time, my lab technician was totally amazed. He was really happy because for the lab technician it's a nightmare. They get a preparation, they bring it into the articulator, they judge it, and they call me normally and say, there's not enough space. So for me as a dentist, this means I have to bring the patient back, get him numb again, remove the temporary, prep again, new impression, takes 1 hour of time. It's a totally waste of time, and for the patient it's a nightmare. So what I do today, I use these prep marker, 1.5 millimeter, and I go all the way from the mesial to the distal, through the middle part, through the fissure of the tooth. And then I go from the buccal aspect to the lingual aspect, and then I'm 100% sure I removed enough. And this is really extremely helpful. If we do tabletops, and I always try, if it's possible, not to do a crown, to come back to the key point of the lecture. If it's possible, I just love to preserve the tooth structure of the patient. And there's a brand new kit in the market. This is developed by Dr. Ahlers and Dr. Edelhoff. This is especially for tabletops, and everything is inside the kit. Everything you need to create a very minimal invasive preparation on the one hand side, and on the other hand side, an extremely precise preparation. So, if this is the tooth before, now you can see it from the frontal view. The first thing we do is we use the prep marker. And as I told you already, I go all the way from the mesial to the distal, and then I go 2 times from the buccal to the lingual aspect. And after doing this, I use this kind of burr. It's the occlu shaper, and this is really absolutely amazing. It's so easy with this burr to do the ideal reduction. It's quick, it's fast, it's precise, and that's what I love. And then I use this kind of burr to create the margin. You have over here, you have the tip, so you cannot go in too deep. It's again extremely precise. And if I have to do an approximal reduction, I use the sonic tips to make sure I don't damage the adjacent tooth structure. So, like here, it's very easy to go through to create a really nice finish line without damaging anything. And that's what I try to perform. Finally, veneer preparation. I'm doing veneer cases since 2003, big veneer cases. And since 2003, I was always telling, please use a depth cutter with 1 ring. Always. Why? Ivan, you remember, you have seen this kind of lecture very often. I was always telling everybody, please use a depth cutter with just 1 ring on it. Because I always try to create 3 depth cuts, 1 incisally, 1 in the middle part of the tooth, and 1 on the cervical part of the tooth. I go all the way from the mesial to the distal, and then I mark everything. The depth cut is into the mock-up. This is quite normal. And then we remove the mock-up and we see directly where we have to prep and how much we have to prep. Why did I always recommend a depth cutter with just 1 ring? Because the tooth is not flat, it's bulky, and we have to follow the shape. So what I was always telling the people, first depth cut in the cervical area, second depth cut in the middle part, and we always change the inclination of the burr to make sure we follow the shape. Like this. But there's a problem. And the problem is, if we work with the wrong inclination of the burr, we can go far too deep into the tooth structure. And we measured it. We can go up to 90% too deep. And 90%, it's definitely a nightmare. So, brand new. It's on the market since the IDS. And here we do have a depth cutter with this shape. And the very special thing is the tip of the burr. Because of this tip, you cannot go too deep. You have to follow the shape of the tooth. And this means from now on, I always recommend, instead of using the one ring burr, this one. Because this one, it's not possible to do it wrong. There's even if you're a beginner, if you have absolutely no experience with veneer preparations, you will never do a mistake. This is 100% safe. You can see this in the next picture. You see here, it's not possible to go too deep into the tooth structure. And that's ideal. It's really a breakthrough. And then finally, to create the perfect finish line, I love to use the sonic instruments, because these are really, if it's a nice preparation, but the finish line is not perfect, it's extremely difficult for the lab technician. We do sometimes veneers with the thickness of less than 1/10 of a millimeter. Sometimes it's 0.05. This means you have to create the perfect finish line, and it's much easier to do this with the sonic instruments compared to a burr. So as you can see here, you go all the way around the buccal area. And the nice thing with the new kit is, for all kind of veneer preparations, you have everything within one kit, everything you need to create the ideal preparation. So, finally, please always try to be as minimal invasive as possible. Always try to preserve the tooth structure of the patient. That's absolutely the key point. Today you will find amazing instruments on the market which are really helpful to create the best for the patient. And always try to preserve again the tooth structure.